there's a reason some people go into medical specialties, and there's a reason some people go into surgical specialties, and a lot of it has to do with your level of interest in minutia. I can remember being on my first internal medicine rotation as a medical student, and I'm not exaggerating at all when I say we spent 45 minutes outside of a patient's room on rounds talking about why the patient's potassium was 3.4 instead of 3.5. If that interests you, you're going to have a great time today. If it doesn't, sorry. It is very important to understand fluid and electrolyte disturbances because they are very common, particularly in hospitalized patients. So in your inpatient population, you'll see lots of patients that have fluid and electrolyte disturbances for various reasons, which we'll get into some of those today. They can be frustrating to diagnose, they can be frustrating to treat. Sometimes they're very straightforward, but like I said, it is important, but you will encounter people in your career who love to nerd out over fluid and electrolyte balances and disturbances, and if that interests you, awesome. If it doesn't, consider a fellowship in emergency medicine, orthopedics, or surgery. So, your learning objectives for today: analyze and interpret the relationship between fluid and electrolyte disturbances and renal pathophysiology. Okay. So we're going to talk about fluid balance and homeostasis, and then we're going to talk about all these different electrolyte disturbances individually. So we'll talk about sodium, we'll talk about potassium, calcium, phosphate, etc. Okay. Now, hopefully, most of this is review. I'm sure everybody knows that human beings are mostly water. The breakdown of where that water is located in the body, most of it's intracellular. Only about 20% of your total fluid volume is vascular, right? Primarily plasma. And it's challenging to figure out whether or not a person has all the water they need to have, where it's located. Sometimes in an inpatient setting, particularly, you see the final bullet there, total body water varies and is sometimes monitored by weight. So a lot of hospital beds have scales built into them. If a patient is fluid overloaded, you got somebody who comes in heart failure, they'll monitor their weight daily as a surrogate for their volume status. But it doesn't really tell you everything you need to know, because there's no way just from looking at a person or looking at their weight to know where that water is located. So again, 20% plasma, 80% interstitial fluid. When you're talking about your extracellular fluid, and then 2/3 of that is intracellular, which you can't measure, right? All right, so some terminology. If you've ever had difficulty differentiating between osmolality and osmolarity, here's your breakdown, all right? So osmolality is solute particles per weight, and osmolarity is solute particles per liter of volume, all right? And then tonicity is the ability of an extracellular solution to make water move in or out of a cell. So don't confuse osmolarity or osmolality with tonicity. Tonicity is simply whether or not there's the ability of water or solutes to move across a gradient. And that's what's really most important. So if you think about something like hemodialysis, so if somebody is undergoing dialysis because their kidneys don't work, you are creating osmotic pressure using the difference in tonicity between the dialysate that's in the machine and the patient's blood to get water and or solutes to move across that membrane in the osmotic filter in a dialysis machine. Right? And tonicity is what determines cell hydration. So if a person is volume down, then their tonicity is going to go up because they don't have enough water, and the concentration of solutes goes up, right? So volume down, solutes, if they stay the same, if they're not losing solutes, then the concentration goes up and the tonicity increases. All right, everybody knows the difference between hypotonic, isotonic, and hypertonic, right? Do I need to read this slide to you? Okay, good. All right, so just in diagrammatic form, so you've got just free water on one side, and you've got sodium chloride on the other side. Water is going to try to diffuse across this notional semi-permeable membrane in the middle, right? Because free water wants to go where the concentration of solutes is higher, not the other way around. The solutes don't diffuse this way. They pull water in. And that's what, when we talk about osmotic pressure, that's what we're talking about. The pressure is, if a better way to think about it might be to think about it in terms of like it being a vacuum, right? So if you, the side that has the higher concentration of solutes is pulling water towards it, and that's your osmotic pressure. So if you want to think about that in terms of the human body, here on the far right side you've got your plasma. In the middle you've got the interstitium between the cells, and then on this side you've got the fluid volume inside the cells. And it's really, it's sort of set up to illustrate that 20%, you know, this is the total 60% water makeup of the body, 2/3 here, 1/3 here, 20% of it being in the sodium, or in the plasma. The main intracellular solute is potassium. Now that doesn't mean potassium is the only solute that's in the cells, but it's the primary one when you're talking about forces that dictate osmotic pressure and fluid balance and homeostasis. And then in the interstitium and in the plasma, it's sodium. So how do you evaluate somebody's fluid electrolyte status and their fluid balance? Well, you measure the fluids that you have access to. And since you can't access the fluid in the cells directly, that means you have to look at what is the electrolyte balance in the serum and what's the electrolyte balance in the urine. And yesterday we talked a little bit about fractional excretion of sodium. We'll talk about that again today. So if you check a comprehensive metabolic panel or renal function panel on someone, you're going to get a snapshot of what their electrolyte levels are in their circulating blood volume, right? And if you look at the electrolyte balance in the urine, you're going to get an idea of what they are losing. And is it appropriate? Are they losing the right amount? And again, the amount that they're losing is, or how you see that is going to be dictated on how much water they're losing also, right? Because if somebody is losing an appropriate amount of, say, sodium, for example, in their urine, but they're also losing too much water, is their urine going to be concentrated or dilute? Dilute, right? If they're losing too much water, even if they're maintaining their electrolyte levels correctly, then their concentration is going to be different based on how much fluid they're losing, and that's where a fractional excretion of sodium can help you determine whether it's appropriate or not. So again, fractional excretion of sodium, here's the formula. Like it says at the top here, the gold standard for renal electrolyte excretion is a 24-hour urine collection, because a point urinalysis only tells you what a person's electrolyte and fluid excretion is at that point in time, and it can vary over the course of a 24-hour period. So if you really want to know what's going on with somebody, you need to collect their urine for 24 hours. 24-hour urine collection is challenging, especially if you're having somebody try to do it in an outpatient setting. How do you make sure that they're only collecting their urine for 24 hours? How do you make sure that they collected for 24 hours and not less than that? Also, what can be challenging for the practitioner is ordering the correct 24-hour urine collection, because there's several different 24-hour urine collection studies that you can order. And depending on which one you order, that's what the lab's going to run. And if you didn't order the right one, you're not going to get the right answer to your question. So just as an example, there's a 24-hour urine collection specifically for protein. So if you suspect that somebody has something like a nephrotic syndrome and you want to know how much protein they're losing over a 24-hour period, then you're going to order that specific 24-hour urine collection. If somebody is a chronic kidney stone former, there is a specific 24-hour urine collection study called a Urorisk panel that looks at their electrolytes and other elements that are present in urine that are specific to kidney stone disease. We'll talk more about that when we get to the lecture on kidney stones. But your standard 24-hour urine collection for electrolytes isn't necessarily going to give you their, for example, citrate level. And citrate concentration is important in calcium stone formers. If somebody makes calcium stones, you want to make sure that their citrate levels are high, because citrate prevents calcium stones from forming. And you're not going to get that if you don't order the right study. So make sure that you know what study you need when you're placing those orders. And then, because 24-hour urine collections are challenging to do, the better thing to do usually is to just look at their fractional excretion of sodium, which we've talked about several times. So it's only a snapshot in time, but it's a whole lot easier to do. You get urine, you get blood, you put everything in the formula, and you find out what's going on. Okay? Like we talked about yesterday, a low fractional excretion of sodium indicates renal reabsorption. So if their fractional excretion of sodium is low, what that tells you is that the kidneys are doing what they're supposed to do in terms of pulling sodium back, right? The body is holding on to electrolytes, and can be an indication of prerenal disease. So if you have somebody who is if you have someone who is hypovolemic from trauma, the body is going to try to hold on to everything that it can, because the baroreceptors and the osmoreceptors in the central nervous system know that things are down, and if the fractional excretion of sodium is low, then you know it's doing what it's supposed to do. If their fractional excretion of sodium is high, and you're talking about a trauma patient, then something is going on that's preventing them from hanging on to their fluid and their electrolytes. If the fractional excretion of sodium is high, then that means that they're dumping for some reason. And that may be appropriate given whatever their clinical picture is, but it may not be, again, depending on what their clinical picture is, and we'll get more into that. All right, so just some normal values here. You don't need to know this. There's not going to be a question on the test that says, what's the normal adult solute concentration? Okay, just so you know, normally it's between 285 and 295 millimoles per kilogram, right? And the osmolarity and baroreceptors in the human body are very effective at determining shifts. So you can see there that you know, a 1 to 2% change is detectable by the body, and then you know, corrections can be made. So when you're thinking about tonicity, you need to keep in mind that there are substances that can be introduced into the human body that can have an effect on osmotic pressure that aren't necessarily going to show up on laboratory values. So let's say you have somebody who comes into the emergency department with their child because they found their kid drinking antifreeze. ethylene glycol is a constituent component of antifreeze, and it has an effect on overall fluid tonicity, but it's not something that's going to show up on a laboratory panel, right? Like you order a renal function panel, there's not a line for ethylene glycol, right? But it is going to have an effect on their osmolality and their tonicity. All right, so again, osmolality gap. If you calculate, or if the lab calculates for you, a patient's osmolality and there's a discrepancy, so you calculate osmolality with this formula, like it says on the slide, don't memorize it, you're not going to be asked to do this. But if you were to plug everything into this formula to calculate a person's osmolality and there's a discrepancy of more than 10, then you have to be thinking about undetectable actors, extraneous influences that aren't necessarily something that's going to show up on a panel. And there's lots of examples of it up there. So ethanol, if you've got a person who's a significant chronic alcoholic, their osmolality is probably not going to be where it needs to be. If they're drinking things they're not supposed to drink, like methanol or antifreeze, if they're an inpatient and they're being treated with mannitol, which is a diuretic, mannitol doesn't show up on any panels. It's going to have an effect on their osmolality. So just think about those things. And again, it all depends on the clinical situation you find yourself in. So just all that summarized in one slide. Osmolarity versus tonicity, and then we talked about hypertonic, isotonic, hypotonic, and the effect that those levels of concentration have on the cells. When you're looking at red blood cells specifically, they're very responsive to concentration levels. If you see red blood cells in the urine, so this is, remember we were talking about crenellated yesterday, crenellated shape, battlements on a castle. Red blood cells aren't built in Minecraft, they're not square. This is what you're going to see, right? This is a crenellated type of appearance to a red blood cell here. If the solution that they're in is isotonic, like plasma should be, then they're going to appear normal, and if it's a hypotonic solution, then they're going to swell. Okay, so primary stimulus for water intake is thirst. Makes sense, right? The body needs water. The way it tells you that it needs water is it makes you thirsty. How does that happen? By a rise in tonicity. Okay? The major stimulus for antidiuretic hormone secretion is hypertonicity. So if your solute concentration is going up, the body recognizes that. It makes you thirsty, and it triggers secretion of antidiuretic hormone, which is one of the most intelligently named hormones of the body. It tells you exactly what it does, right? Aldosterone does not tell you what it does. Antidiuretic hormone, pretty straightforward. It triggers reabsorption of free water in the kidneys, right? All right, so let's talk specifically about sodium for a little bit. So serum sodium reflects relative amounts of sodium in water. You're going to see this as a recurring theme. Serum sodium, serum anything, electrolyte-wise, doesn't tell you everything you need to know about a solute concentration across the person's entire body, right? So it's not total body sodium, it just tells you the relative ratio of sodium in the bloodstream relative to the amount of fluid in the bloodstream. And we'll get more into that. You'll see some slides here later on, if you haven't looked at them yet, with the notional glass half empty, half full, overflowing, and it's a good way to think about electrolyte concentration versus fluid volume status, all right? So you can have someone who on their laboratory values is hyponatremic, so their serum sodium level is below normal, but their volume status, they could be hypovolemic, not have enough fluid volume, euvolemic, have all the fluid volume they're supposed to have, or they could be hypervolemic, have more water than they're supposed to have, and yet their serum sodium level is still below normal. So keep that in mind. Just because somebody is hyponatremic does not necessarily mean that they're volume overloaded. They might not be. Okay, so again, values, you're not expected to remember these. Right? I can promise you that on any exam question that you have for me that's about fluid electrolyte imbalance, I'm not just going to give you a number and you're expected to know, like, is that normal? Is it high? Is it low? It'll tell you, okay? But it is important to note that 120 milliequivalents per liter or lower in sodium concentration is a significant hyponatremia, okay? And as I've already said, their total body water could be normal, it could be low, it could be high. Hyponatremia is the most common electrolyte abnormality you'll see in hospitalized patients. It's by far the most likely thing you're going to see in terms of electrolyte abnormalities is going to be a sodium imbalance of some sort. Okay, so here's your sort of thought tree for working your way through hyponatremia. All right, we're going to go through this in sort of a stepwise fashion. But so how do you determine that somebody's hyponatremic? You get a metabolic panel on them, right? And I don't know how much laboratory terminology y'all have had up to this point, but CMP is a comprehensive metabolic panel, right? So a comprehensive metabolic panel is going to show you all of a person's serum electrolytes as well as their liver enzymes. If all you're concerned about is kidney function, a comprehensive metabolic panel is probably overkill, and it is more expensive than doing a basic metabolic panel or a renal function panel. So if you're not interested in somebody's liver enzymes, you don't necessarily need to order a comprehensive metabolic panel. Really, most important from a speed of getting your results back, you're going to get your results back faster the narrower the test that you order, and also from the consideration of expenditure. So you get your laboratory values, right? And then you look at the patient's osmolality, and then that takes you down one of these three trees. Okay, and we'll talk about each of them. All right, so hypertonic hyponatremia. So their serum sodium is low. Well, let me strip the next slide. Here we go. So if they're hypertonic but hyponatremic, then that means that there's probably something else causing an effect on their osmotic gradient that you're either not seeing or you are seeing. So all those things that we mentioned before, mannitol, ethylene glycol, that sort of thing, or maybe they're in diabetic ketoacidosis. Or you don't have to be that far. You can just have somebody who's a really poorly controlled diabetic and their blood sugar's 500. And as a result of that, okay, so now they've got a whole lot more sugar in their blood than is supposed to be there. So it has an effect on the tonicity and the osmotic pressure. So what is happening there? Why are they hypertonic yet hyponatremic if they're hyperglycemic? What's the effect based on what we've already talked about? There you go. So there's water being retained in the intravascular space because it's trying to move to where the higher concentration of solutes are, and the water is redistributing, right? And so their sodium level isn't changing. Their sodium level is staying static. The body's normal mechanisms for maintaining sodium homeostasis are in effect, but water is moving And so their tonicity is higher due to the sugar, and their measured sodium level is low because there's more water in the intravascular space than there's supposed to be. Okay? Does that make sense? It's real easy to get these confused. It's very frustrating too in a clinical setting when you're looking at somebody who's hyponatremic and you're like, okay, why is this person hyponatremic? What's going on with them? All right. So in hypotonic hyponatremia, now they've got excess water and they've got not enough solutes. Right? So that the concentration of dissolved solids is lower. So is it because they're sodium wasting? Is it because they're, so a good example in a military population or any athletic population is if you have somebody who's engaged in rigorous physical activity and they're sweating a lot and they're not eating and all they're drinking is water, they're losing electrolytes through their sweat and not replacing those electrolytes, but they are replacing fluid volume. So in its most severe form, you can see what's called water intoxication. So when I went through basic training back in 1999, right after I got back from basic training, there was a trainee at Lackland, here going through Air Force BMT, who died from water intoxication. He was 18 years old. They were on their final field training exercise. They were on their ruck march back, and he wasn't feeling well. He complained to his drill instructors. He complained to the medics that were there that he wasn't feeling well, and nobody ever laid hands on him. When they did the investigation afterwards, what was determined was that nobody got closer than about like this, and they just told him to drink more water, which is like the most military response ever for somebody not feeling well, right? Drink water and walk it off. And he made it across the finish line from the ruck march and then promptly collapsed and seized. And they took him to Wilford Hall, which at the time was a full-service hospital, level 1 trauma center, in fact. And they pumped his stomach in the emergency department and got 1.5 gallons of water out of his stomach, and he'd just been hammering water for the whole ruck march. When they stopped for meal breaks, he didn't eat anything because he didn't feel well, and he had significant electrolyte abnormalities. And while they didn't get into the finer medical details in the reports that were published in civilian newspapers, I suspect that he probably had demyelination of the central nervous system. That's something that can happen when you have somebody who's significantly hyponatremic. It has a serious effect on neurons, which we'll talk about a little bit. And his brain swelled and he died. It was a significant emotional event for the Air Force writ large, and obviously for the service member and his family. But that's a pretty extreme example, but it's one way to think about it. If you have somebody who is losing solutes for some reason, in this case physical exertion, and they're not replacing those solutes, but they are replacing their fluid volume, then you're going to potentially end up with somebody who's got hypotonic hyponatremia. Okay. All right, so if you determine that somebody has hypotonic hyponatremia, then you have to look at their volume status and determine, are they hypovolemic, euvolemic, or hypervolemic. So as I mentioned earlier, we're going to consider the glass, right? Think of the person in terms of the glass. Is their glass mostly empty? Is it where it's supposed to be, or is it overflowing? So in hypovolemic, well, we'll get into it on the next slide, so I won't start talking about it now. But so you've got hypovolemic, hypotonic hyponatremia, euvolemic, hypotonic hyponatremia, and hypervolemic, hypotonic hyponatremia. Right? So if they are hypovolemic, glass is not as full as it's supposed to be, you'll probably see other signs of that on just looking at the patient. Do they have xerostomia? Do they have dry mucous membranes? Do they have tinting of the skin? So in hypovolemic hypotonic hyponatremia, they're losing sodium and water and replacing it with hypotonic fluid. So what can cause that? Diuretics are one thing that can do it. If you have someone who has an inappropriate antidiuretic hormone response, or it might even be appropriate, and the end result is they're holding on to free water, right? Then they can end up with a hypovolemic hypotonic hyponatremia because they're trying to maintain their intravascular volume, yet they're still volume down. So they're volume down, they're trying to pull in free water, but they're not getting volume replacement elsewhere. So they're not drinking, they don't have IV fluids running, so their total volume status is down, but they're still trying to pull in extra fluid from the kidneys. They're reabsorbing, and so it's resulting in a hypotonic hyponatremia, right? And again, your urine sodium can give you a clue to this. Your fractional excretion of sodium can give you a clue to this. So if their urine sodium is greater than 20 milliequivalents, then it's potentially a renal problem. And if their urine sodium is below 10 milliequivalents, then it's potentially an extrarenal problem. You're not going to have a question on the exam that says, is this a renal problem or an extrarenal problem? You just know that this is one of the things you can look at to help you determine, is this a kidney problem or is this something outside of the kidneys? All right, so euvolemic hypotonic hyponatremia. So here's where you got things like your syndrome of inappropriate antidiuretic hormone, hypothyroidism, if they have a glucocorticoid deficiency because they infarcted an adrenal gland, or maybe they've been on chronic glucocorticoids and they ran out, or they didn't do an appropriate taper, then that can cause this. Malignancies can have varying effects on electrolyte balances. Why? Why is that?
Increased calcium?
So calcium is one of the ones that can be affected, but why is it? Why does that happen? So various malignancies, as a byproduct of their metabolism, can secrete molecules that are similar in structure to normally occurring hormones in the body that have an impact on electrolyte balance. And so you may, this is actually a pretty good example of one of those incidental findings. Like, you might have somebody come in for their annual follow-up and you check a comprehensive metabolic panel on them and you notice that their calcium is elevated. And you say, well, why is this person's calcium 12? There's no reason for them to have a calcium of 12. And you start digging down that rabbit hole and you find out they've got renal cell carcinoma. Because hypercalcemia is something that can occur in patients with renal cell carcinoma, and it's because the cancer itself is producing molecules that result in increased calcium concentration, either by reabsorption of calcium, or it may have a parathyroid hormone-like effect that's affecting the calcium concentration in their bones. The other thing you can see happen is if they've got advanced cancers and they've got tumors that have metastasized to the skeleton and it's lysing their skeleton, then you can see an increase in serum calcium as a result of just the breakdown of the skeleton. But the point is that malignancies can have effects on all electrolytes. So it's not just necessarily going to be calcium or sodium. It can be potassium as well. And it depends on what type of cancer they're dealing with. So reset osmostat. So what that is we see this a lot in pregnancy. So the brain, the osmostat in the central nervous system, the hypothalamus, recalibrates itself based on the fact that the person is growing another person, right? And so you can see electrolyte imbalances in pregnant women that don't have any clinical impact on them. You look at the lab value in a vacuum and you go, well, that's not normal. They're hyponatremic. But for them, physiologically, it's normal. It's because their osmostat has reset, their fluid volume and their electrolyte concentration is expected to be different because of the pregnancy. So seeing some mild hyponatremia in pregnant females is not uncommon, and it's not anything you have to do anything about. And we already talked about exercise induced hyponatremia. All right, so euvolemic. So again, antidiuretic hormone can play a role in euvolemic hypotonic hyponatremia. Your syndrome of inappropriate antidiuretic hormone can also manifest as a euvolemic hypotonic hyponatremia. And then again, we've talked about malignancies. So you'll see malignancies as a recurring theme here. The person's overall volume status may be low, maybe high, maybe normal, and there could be a malignancy at play behind the scenes. And like it says, common cause of euvolemic hyponatremia, hypotonic hyponatremia in hospitalized patients. So other things that can cause it, a low solute diet. So if you've got somebody who's got beer potomania, if all they're drinking is beer and nothing else, and they're not eating anything, like your hardcore alcoholics. If you have somebody who's on a tea and toast diet, this is something that they, when I learned about it, they would describe like the elderly homebound person who doesn't get out to do grocery shopping. They just eat what they have available to them at the house, and it may not be much, and it may not be very substantive in nutritive content. Tea and toast diet. Again, we talked about reset osmostats already, and then that exercise-associated hyponatremia. All right, lots on this slide. It's just a summary of conditions that can result in syndrome of inappropriate antidiuretic hormone secretion. Again, you don't need to memorize it, but it's there for your reference. All right, so if we've gone down the euvolemic tree, how do we determine what's going on? Well, look at their urine osmolality, right? So if their urine osmolality is less than 100, then what does that mean? What I mean is, what is their urine look like? If the osmolality is less than 100, is their urine concentrated or is their urine dilute?
Dilute.
It's dilute, right? So be thinking about things like psychogenic polydipsia or a low solute diet. If their urine is concentrated, particularly if it's significantly concentrated, then be thinking about things like syndrome of inappropriate antidiuretic hormone, right? Because if they've got antidiuretic hormone going crazy, then the kidneys are reabsorbing all the free water that they can, which means what comes out in terms of urine is going to be extremely concentrated. And then hypothyroidism or glucocorticoid deficiency. And then if they have something like a reset osmostat, their urine osmolality may be variable. All right, so let's talk about hypervolemic. So I didn't recognize the significance of it at the time, but the first time I ever saw pretibial pitting edema was again in basic training. So we had all right, is everybody awake now? So it was an incidental finding. One of the guys in my platoon just took his socks off and noticed that he had some significant swelling in his lower legs, and he started pushing on them, and it left finger indentations in his legs. And we showed it to the drill sergeants, and they're like, "Oh, that's weird." And that was the end of it. That was there was nothing. He didn't go to sick call. Like he was fine. Nothing happened to him, fortunately. And again, I didn't recognize the significance of it at the time, but now knowing what I know now, like, oh boy, there was something. He was volume up for some reason. All right, so cirrhosis, liver failure, your nephrotic syndromes, advanced renal diseases. So why would advanced renal diseases result in a hypervolemic, hypotonic hyponatremia? Louder? Right. So the whole system is just breaking down. Right. They're not secreting their solutes correctly, or they're not retaining them correctly, and they're not able to get rid of free water, and so they end up retaining free water, which pushes their serum concentrations down. Right. Increased water in relation to sodium is hypervolemia. Right. So you may look at them and they may look completely normal. They may not have pretibial pitting edema, but their volume status is up, and that ends up making their serum concentration low, and so they're hypervolemic, right? So be thinking about these things. All right, so clinical findings in hyponatremia. Back on my belt real quick. So, as I mentioned earlier, mainly neurologic abnormalities. So, like the example I gave you of the airman who went down with water intoxication, he had a seizure, right? And it's kind of an extreme initial presentation. There were probably other things that were occurring up to that point that nobody noticed. But having neurologic signs it's very, very common, and largely that's due to swelling in the brain. So if somebody is hyponatremic, the fluid shifts that take place can occur in a lot of places, but significantly in neurons, right? So that free water starts following that osmotic gradient into the neural cells, where there is a higher concentration of calcium and potassium and sodium, and it causes the brain to swell. And so they can end up with in extreme cases, seizures and death. But if you have somebody who is chronically hyponatremic, so take the example of that chronic alcoholic, they might have a sodium of 115, and they're just walking around happy as a clam with no outward signs, because it's something that has taken time to develop, and their body has just sort of adjusted to that being the new normal. You still have to be careful in correcting their you have to be more careful in chronic patients. But if you correct somebody's hyponatremia too rapidly, regardless of whether it's an acute situation or a chronic situation, so you had cerebral edema, now the problem you're going to end up with is demyelination, which is worse. So if you correct somebody's hyponatremia too rapidly, the neurons can demyelinate, and that's a much more challenging problem to come back from, because myelin doesn't necessarily like to regrow. But you can see here just things that you'll see with mild hyponatremia versus severe hyponatremia. So headache, lethargy, again, probably things that airman was exhibiting earlier on in his rug march that nobody really noticed. They just attributed it to being tired from being on a field training exercise. And then seizure, coma, brainstem herniation, and death, which is probably what happened to him after he crossed the finish line and went to the hospital. So how do you assess these patients? There is no substitute for a detailed history and physical. I mean, there just isn't in any situation. We're not just talking about hyponatremia. If you talk to a patient long enough, they'll probably tell you what's wrong with them. And I don't mean that to say that if you have a long-winded patient who likes to go off on tangents and things, they'll finally tell you why they're there. That also happens. But there's an old axiom in medicine that if you just listen to somebody long enough and hear what they have to say, you'll probably figure out what's going on with them. So you know, we practice in an era of 15-minute appointments where you don't have a lot of time to spend with patients, but there's a lot to be gained from getting a good history. Things you want to know about are things that affect their fluid level, fluid output, fluid intake, right? So have they been vomiting? Do they have chronic diarrhea? Do they have an ostomy? So if you have a patient who has an ileostomy or a colostomy for some reason, that can have a significant impact on their fluid status and their electrolyte status, depending on what segment of bowel was removed, how much they have left, etc. Are they making enough urine? Are they making too much urine? And always think about insensible losses. So just as a simple experiment for yourselves, I don't know if you've ever done this before, weigh yourself before you go to bed, and then weigh yourself in the morning. I guarantee you that there will be a slight difference between your weight. It might be a significant difference in your weight from when you went to bed and when you woke up in the morning. Well, what happened? Where did that weight go? Some of it might be fat reserves being burned overnight if you're in a calorie deficit. But the more likely explanation is insensible losses. You've lost fluid volume. Even if you don't remember sweating overnight, like you didn't wake up in a puddle, you still sweat. And you lose an incredible amount of fluid just in your expired breath, right? So always consider insensible losses. And then, are they eating? Are they not eating? What are they eating? What are they drinking? Think about new medications. You know, like we talked about, diuretics are a big culprit when you're thinking about fluid and electrolyte imbalances. So did they recently started on a thiazide or a loop diuretic? And then on physical exam, look for signs of their volume status. So do they have dry mucous membranes? Do they have skin tinting? Do they have pretibial edema? And then look at their laboratory assessment. Okay. Treatment. So one of the most common things you're likely to see that's going to result in fluid and electrolyte abnormalities is going to be hyperglycemia. Diabetes is a huge problem in the United States, and you're going to see a lot of people that are poorly controlled, even in the military population, because you've got dependents, you've got retirees, and like I mentioned before, you want to be careful about your correction, whether it's you're correcting their hyperglycemia or you're correcting their hyponatremia. You want to be careful because all of those fluid shifts can have an impact on the health of the brain. And if they're on mannitol for whatever reason, discontinue it as needed. And then once you've identified what the underlying etiology is, take care of it. But again, caution regarding rapid shifts, right? Because you don't want to cause demyelination syndrome. Okay, so always address the underlying etiology. I mean, that's going to be your key hallmark for all of these is figure out what's going on with them, and then address it. Whether it's so in the case of hypovolemic hypotonic hyponatremia, they may need fluid resuscitation, or they probably need fluid resuscitation. If they're a trauma patient, you're already going to be doing that anyway, right? You're going to be giving them, you know, saline or lactated ringers or whole blood, it's almost always going to be isotonic fluid. There are situations where you're going to potentially be giving somebody hypertonic saline. So what's the saline concentration in normal saline? 0.09. What's the concentration in hypertonic saline? 3%. It's a pretty big difference, right? So there are situations where you might give somebody a hypertonic fluid, but most of the time you're going to be giving them isotonic fluid, so you don't cause significant rapid shifts in their balance, all right? Diagnostic fluid challenges are still done. I can't remember the last time I saw somebody be given a diagnostic fluid challenge to see what results it had on their clinical response as far as heart rate, blood pressure, and mentation. Again, you run into the situation of correcting too fast versus correcting too slow. But it is something that has been done historically. And then if they're hypervolemic, you want to get that excess volume off, right? And if they're in renal failure, that may require dialysis. If they're a cirrhotic patient, then you might see somebody who comes in with significant ascites and has 10 liters of fluid in their abdomen. Do you want to pull all 10 liters off at once? No. What is cirrhotic? Well, what is ascites full of? I think I heard somebody say it.
Protein,
Louder.
leukocytes, depending.
Did I hear somebody say protein? Yeah. So if you pull off all that acidic fluid, sometimes you will give hypertonic saline to correct somebody's hyponatremia. I have never seen hypertonic saline given outside of the ICU, because you have to monitor those patients closely and make sure that they don't have any neurologic sequelae from the rapid correction in their sodium levels. Neurosurgeons will use hypertonic saline a lot, especially if they're trying to correct something like cerebral edema. And it's always done in an ICU setting. Sometimes you'll hear hypertonic saline referred to as hot salt. So if you get out there to your clinical rotations and you hear somebody talk about a patient getting hot salt, what they mean is they're getting ready to give them hypertonic saline. Okay, so same chart we looked at before, just sort of a summary of everything that we've talked about, and how you manage those various scenarios. Okay, so hypernatremia. So they've got too much salt. Again, you got to get down to what the underlying cause is. Are they volume down? Are they euvolemic? Are they volume up? Figure out what the underlying problem is, and treat accordingly, right? So, is it free water loss? Is it hypotonic fluid loss? Are they taking in too much salt or retaining too much salt for some reason? So, if their sodium concentration is greater than 145 milliequivalents per liter, then they technically have hypernatremia. And if they're hypernatremic, they're all hyperosmotic, right? They've all got hyperosmolality. And usually it's due to hypotonic fluid losses. So if they're not producing antidiuretic hormone, or if their nephrons aren't responding to antidiuretic hormone for some reason, then is their fractional excretion of sodium going to be high or low?
Low.
Low.
It's going to be low, right? Good. Okay. They've got too much sodium in their bloodstream, right? We're talking about people that are hypernatremic, and because they're losing free water, they're not concentrating. Okay. So normally, if somebody has high osmolality, it triggers thirst. But if there's something wrong with their thirst centers, then they may not feel like they need to drink anything, and as a result, they're going to be losing free water, and they'll end up hypernatremic. Yeah, and just like with hyponatremia, neurosymptoms predominate. So if they're hypernatremic, their water is going to try to move to where the sodium is, right? So instead of having cerebral edema, they're potentially going to have shrinkage of the brain, right? Fluid's going to be flowing out of the brain, and that's why you can end up having neurologic symptoms in patients that are hypernatremic. Neurons don't like change. This is very true. Neurons don't like any sort of change. They don't like to be overfull. They don't like to be empty. They don't like to be stretched. They don't like to be cut. And they don't bounce back well, right? We all know that. You know, somebody gets a spinal cord injury, that's it, at least for now. Hopefully that'll change someday. And like it says here on the final bullet here, that the symptoms are more dependent on the rise in serum sodium than the absolute value. So just like with hyponatremia, when you're talking about correcting it, it's not necessarily about what the total value is, it's how quickly did they get there. The more rapid the change, the more likely they are to have neurologic symptoms. If it's a slow process, then the body is usually able to compensate for that change. That's why you can have, going back to hyponatremia, that's why you can have those chronic alcoholics that have significantly low sodium levels and don't have any outward neurologic signs because they've just slowly gotten to that point and they've tolerated it. Symptoms are very similar. So lethargy, irritability, just like with hyponatremia. In more advanced cases, they can end up with hyperthermia, delirium, seizures, coma, just like with hyponatremia. And if they're elderly, then the symptoms may be very nonspecific. You will find that is a recurring theme in elderly patients. And I'll give you another example that's germane to this block of instruction. If one of you developed a urinary tract infection, what would your symptoms be? Generally speaking. Frequency, urgency, maybe burning with urination, dysuria, right? If a 80-year-old person develops a urinary tract infection, are they likely to have those symptoms? They probably will. They probably will, but what are they also likely to have?
Confusion?
Altered mental status. So you can have an elderly person who's brought in by EMS to the emergency department that you're working in, who's totally off their rocker, where they were completely lucid the day before, and your first thought might be, oh my gosh, did they have a stroke? You know, what happened? And it could be something as totally simple as a urinary tract infection. In fact, it's a very common cause of altered mental status in elderly people. So the point is, if they're old, the symptoms that you're seeing may not necessarily line up with what's actually going on with them from a clinical standpoint. So, and just what do we define as severe hypernatremia? There you've got greater than 158 milliequivalents per liter, and you can see here what symptoms you're likely to see based on their serum osmolality. You know, it could be somnolence and confusion. It could be coma and death, just depending on how significant their changes are. So what findings are you going to see on laboratory values? So their urine osmolality is usually greater than 400. So that's assuming that the body is capable and trying to correct their hyperosmolality in the serum, right? So if their antidiuretic hormone is working, then they'll be concentrating their urine and trying to replace fluid volume in the intravascular space. But if they're not, you can still have somebody who's got dilute urine and is hypernatremic. And again, diabetes. If their diabetes is significant enough that they're dumping glucose in their urine, then that will result in potential volume depletion because it's damaging the abilities of the nephrons to do what they're supposed to do, and it's causing an osmotic gradient that's pulling fluid with it. So as I mentioned, they can have hypernatremia and not be concentrating their urine the way that they're supposed to. So that's a characteristic of diabetes insipidus. So what's the difference between central and nephrogenic diabetes insipidus? What does that mean? So what structure in the brain is responsible for the cause of diabetes insipidus? Pituitary, right? So if somebody has a pituitary infarct or a head injury that damages the sella turcica, then they can end up with central diabetes insipidus. And then nephrogenic diabetes insipidus is just a nephrogenic cause of something that looks like diabetes insipidus. So when you see the term nephrogenic diabetes insipidus, that doesn't necessarily mean that there's something going on with their pituitary, but the end result, the clinical picture, is the same. The electrolyte abnormalities are the same. And it may be due to renal insensitivity to antidiuretic hormone, or it may be something else. So, correct the fluid loss, do it slowly, just like with everything else we've talked about, because if you do it rapidly, you're going to hurt them more than you're going to help them. In the case of hyponatremia, you're worried about demyelination. In the case of hypernatremia, you're worried about actually causing that cerebral edema that you would have seen at baseline in somebody who's hyponatremic. But like it says here, in acute hypernatremia, so if it's something that's started over a short period of time, you do want to correct it more quickly than you would in chronic hypernatremia, so that you can avoid things like demyelination and morning encephalopathy. And these patients obviously are going to be admitted, and you're not just going to be consulting medicine, you're going to be consulting nephrology and probably critical care medicine too. So if you can use, you should always try to use isotonic solution of some sort initially. If they're hypernatremic and you give them an isotonic solution, you are gradually going to push the concentration down. At face value, it can be sort of counterintuitive. They've got too much salt, so why am I giving them normal saline? The end result is that the concentration still goes down because you're taking them from a high level and giving them a lower level. Every once in a while, you will actually see free water given IV. It doesn't happen very often. It's bad for the cells at the point of infusion, right? Any red blood cell that's going past wherever that IV line is potentially going to lyse because of the sudden change in osmotic gradient. But it is done occasionally, but more often than not, you're going to be using an isotonic solution of some sort. And then over time, you have to calculate what their free water deficit is to determine how much you're going to continue to give them. So here's the formula for it. Don't memorize it. It won't be on the test. Just know that it exists, and that's what it is in case you're ever in a situation that you need to use it. And you can see here what the total body water shift is in somebody who's hypernatremic. And it varies by sex, just because fluid distribution is different between males and females anyway. But in hypernatremia, total body water is 50% in men, 40% in women. And if you have someone who has an intact thirst mechanism and they're not obtunded, then one of the things that you can do to correct their hypernatremia is just have them drink the thirst. You don't necessarily have to be giving them IV fluids unless that's your only option for getting fluid into them, right? If you have somebody who comes in hypernatremic because they got lost in the desert at NTC and they're super dehydrated and hypernatremic as a result, but they're conscious, then you may be able to correct their electrolyte abnormalities just by having them drink, right? Let the body fix itself. If they're not able to drink, then you're going to be rehydrating them by IV. And in the case of chronic hypernatremia, like it says here, you want to correct it slowly, not to exceed 10 milliequivalents per liter per day. Doing it more rapidly than that may result in cerebral edema. And you're going to be monitoring their serum sodium every 2 to 8 hours. If you're on the 2-hour side of things, they're going to be in the ICU because they don't check lab values more frequently than twice a day on a regular med-surg ward, and maybe every 4 hours in a step-down unit. So if you're going to want to check it more than, as frequently as every 1 to 2 hours, they're going to be in the ICU for that. So, like I mentioned, oral water is a great solution for patients who can drink safely. And if you have the ability to give them isotonic fluid, so if you're someplace where you can give them something like Pedialyte, great. If not, just give them water, and they'll usually self-regulate. If they're hypernatremic but they're euvolemic, then you may be giving them a 5% dextrose solution, because that helps get rid of the excess sodium in the urine. So in addition to replacing their fluid volume, you're not really replacing fluid volume in a euvolemic patient, but you are helping push the sodium out. And then if they're hypervolemic, same thing, you're going to give them the 5% dextrose solution, and then you may add on a loop diuretic, because that's going to cause them to lose water and sodium. And then they, again, may require hemodialysis, even though they're not in renal failure. All right, so in summary, these are the things you're going to do for an inpatient with hypernatremia. All right, potassium. So, hypokalemia, we're back to my nightmare scenario of why is this person's potassium 3.4 and not 3.5? We're going to talk about it for 45 minutes outside of the patient's room. So if you have somebody who's got a metabolic alkalosis, which we're going to talk about more tomorrow in our acid-base abnormalities lecture, then that can cause intracellular shifting. The most common cause, though, is a gastrointestinal loss. So if you have somebody who has chronic diarrhea, chronic vomiting, whether that's due to a medical condition or if it's self-inflicted, so think people with like anorexia or bulimia. If they're taking emetics or if they're taking laxatives, then they may have significant shifts in their potassium levels. Medications can do it, obviously, if they have hyperaldosteronism for some reason, and very, very rarely it's due to insufficient dietary potassium intake. You'd have to have somebody who is coming from a significantly stressful environment where they just didn't have access to normal caloric intake, like maybe somebody who'd been lost at sea for a while in a life raft and didn't have a way to get much in the way of intake. They may have hypokalemia. If they're hypokalemic and acidotic, then they may have really profound potassium depletion. So it may not be a case of electrolyte shifting between the intracellular and extracellular components or compartments. It may be that they really truly have significant potassium depletion. Again, we'll talk about that more in the acid-base lecture. So in moderate hypokalemia, muscular cramping, weakness, fatigue. If it's really, really severe, again, this is a recurring theme, as I mentioned, for all of these electrolytes, is you're probably going to see neurologic symptoms of some sort. So flaccid paralysis, hyporeflexia, hypercapnia. Again, if they're acidotic, they're definitely going to be hypercapnic. They may end up with tetany, and they can develop rhabdomyolysis as a result. But the thing you need to worry about the most when you're talking about potassium, whether it's hypo or hyperkalemia, is cardiac manifestations. So if you have somebody who comes in to the emergency department for whatever complaint, and you check their electrolyte levels and their potassium is either significantly high or significantly low, what's the next thing you're going to do for that patient? EKG, right? Make sure that they don't have some cardiac manifestation already brewing. You don't want them to end up, in some significant arrhythmia and have them coding there in front of you. So on your laboratory findings, what you want to establish is the problem is it renal or non-renal? Is it a case of excess potassium secretion? Are they losing potassium, or are they diluting their potassium levels? Right, just like with sodium. And then you can also calculate a urine potassium creatinine ratio using just a spot urine sample, right? Just like you can do a fractional excretion of sodium, you can do a potassium creatinine ratio. All right, so on that EKG that you ordered on your patient who showed up with hypokalemia, this is what you're potentially going to see. So decreased amplitude, broadening of T waves, flattened T waves, prominent U waves. They may have PVCs and they may have depressed ST segments. Hopefully you have gotten a lot of this in your EKG class. It's Dr. Love that teaches that, right? Yeah. So I'm not going to try to be as proficient as her. I am a urologist after all. If you have me reading your EKG, you're in big trouble. Something went wrong somewhere. So here's just a chart that shows you what the abnormalities are likely to be based on a patient's serum potassium concentration. So if it's 3.5, which is the lower limit of normal, down to 2.5, these are what things are going to look like on that EKG. So how do you treat it? Well, if it's because they don't have enough potassium, you give them potassium. Potassium is also something that can be replaced via dialysis. So if you have a patient who's really bad off, they may end up on dialysis. If it's isolated hypokalemia, then either replacement with oral potassium supplementation, and then in a real significant situation, you might be giving it IV. IV potassium hurts. So giving IV potassium through a peripheral IV is something you try to avoid. If you're in a situation where somebody needs IV potassium, you're probably going to be doing it through a PICC or a central line of some sort, because it's really uncomfortable. Patients will not like you if you give IV potassium through like their AC or a small gauge IV that they've got in the back of their hand. Either way, you need to be monitoring their ECG to make sure that they don't end up with some sort of arrhythmia. And then you want to avoid glucose-containing fluids to prevent further shift of potassium into cells. We'll talk more about that when we start talking about hyperkalemia and diabetic ketoacidosis. And then if you're giving somebody potassium and it's not staying up, or it's not increasing at the rate that you think it should be based on the potassium that you're giving them, if you haven't checked their magnesium level, check their mag. Because if their magnesium is deficient, then they're not going to be able to hold on to potassium the way that they should. And magnesium is not something that is on a regular renal function panel. I'm not sure if it's on a comprehensive metabolic panel either. But if this is happening and you haven't looked to see what their magnesium is, order magnesium. All right, so hyperkalemia. Verify the level. Why is this a common lab error? I heard somebody say it. So cell lysis, right? Where is the majority of potassium located? Intracellular. So if the specimen lysed, either because it was collected through too small a gauge of a needle, or something happened to it in transit between collection and the lab, then that potassium that was intracellular is now going to be extracellular, and it's going to be detected on your serum electrolyte levels, right? So if you have no reason to suspect that the patient has hyperkalemia, like maybe you have a patient who's been inpatient for several days for something completely unrelated, their lab values have been completely normal, and one morning you get their labs back and their potassium is 6. What are you going to do? just reorder it, right? You're not going to freak out and start treating them like they've got hyperkalemia. You're gonna have them repeat the lab work and make sure that it wasn't a lab error. If it's real, it may be because they're acidotic. It may be due to rhabdomyolysis, because again, the location of most of the potassium is intracellular. So if they're lysing all of their muscle cells, then you're going to see more potassium in the bloodstream. And then you can read the rest here down the list. I'm not going to read it all to you, but the one I will point out is tumor lysis syndrome. So we talked about malignancy and the effect that malignancy has on electrolyte levels. If somebody is being treated for their cancer, like you've got somebody who's getting active chemotherapy or radiation, and they're killing large numbers of cancer cells. Cancer cells, just like normal cells, have lots of potassium in them. And as those cells die, it gets into the bloodstream, and if it's not being cleared fast enough, then the patient can end up with hyperkalemia. Death from cardiac arrhythmias. This is what you're worried about, right, with hyperkalemia. This is why it's something that needs to be addressed quickly. And again, I'm not going to get into all the EKG findings because you've already heard this before, and I'm not going to do it any better than Dr. Love. But here's your peaked T waves that you'll see on an EKG in somebody with hyperkalemia. And then back to that same chart again. So if they're hyperkalemic, this is what the EKG changes are going to look like. So how do you prevent, or how do you treat it? The best thing to do initially is prevention. If you know that you're going to be doing something to a patient that's likely to result in hyperkalemia, just be careful. So if you've got somebody who already has baseline cardiac, liver, or renal disease, be cautious with medications that can have an impact on their potassium levels, right? If you find hyperkalemia, confirm it, unless you already have a real strong reason to suspect that it's real. And then if it is real, treat it, right? Identify the underlying etiology, don't give them potassium, and then if they need to be treated emergently, with potassium shifting regimens, then do that. So, how do you do that? How do you stabilize them? IV calcium gluconate is the first thing that you want to give somebody because it stabilizes the myocardium. So IV calcium gluconate does not fix the problem with the potassium. You're buying time to do the other things that you need to do to correct their potassium levels. So what you're doing is you're stabilizing the myocardium to protect it against arrhythmias. And then give them insulin, because that will push potassium from the extracellular fluid to the intracellular fluid. Again, you're not correcting the problem permanently by doing that. You're moving things around to prevent them from having a heart attack, right? You're preventing them from going into a cardiac arrhythmia that turns out being fatal. You can also give them a beta agonist, albuterol by nebulizer. Every time I've seen somebody treated for hyperkalemia in the emergency department, they just do all this. It's not and or, they just do it all. They give them calcium gluconate, they give them insulin, they give them albuterol, and then remove the excess potassium by whatever means you need to do that based on what their presenting situation looks like and how acute they are. So up to and including dialysis. All right, everything we've just sort of talked about, chart form, there for your reference. Calcium. Chronic kidney disease and hypoparathyroidism. These are the things that cause hypocalcemia, right? So the most common cause of low total serum calcium is hypoalbuminemia. So if you see somebody with low calcium, check their protein levels if you haven't. If you don't know what their protein looks like. If you have a chronically ill patient, again we get back to those elderly people, or somebody who maybe has had a really large surgical procedure of some sort, their body may be burning through protein in an effort to repair whatever was done to them. So you want to make sure that they have adequate protein levels to make sure that they have normal circulating calcium. So hypoalbuminemia doesn't necessarily cause the person to have low total calcium, but it's going to result in low serum calcium, which can be a problem. and you're not necessarily going to get an accurate measure of what their calcium levels are if they have low protein. If they've got hypoalbuminuria, hypoalbuminemia, then the levels that you're checking are not necessarily going to be accurate. And in that case, then you can calculate corrected calcium. There's a formula for that by taking into account what their albumin concentration is. Just keep that in mind. So, you think we're going to find some neurologic symptoms up here? Yeah. Okay. Just like everything else, they're going to have potentially neurologic symptoms of some sort: cramps, tetany on the low end, convulsions on the high end. They may also have some like non-specific things like perioral paresthesias. Has anyone besides me been in a low altitude chamber for like flight training? Anybody? All right. Did you get perioral paresthesias when they started cranking down the oxygen level? Yeah. So if you've never experienced it before, it's weird, but it's very it's very obvious to people when it's happening. So if you have somebody who says, like, "Oh, my face feels numb," then be thinking about hypocalcemia. Spastek sign, I've never actually seen it, but it is a known sign of hypocalcemia, and just another reason why history and physical exam is so important, because you can literally just tap on somebody's face and see a physical manifestation of the fact that their calcium levels are low. And then Trousseau sign, carpal spasm, right? So if you just put a blood pressure, if you're checking their blood pressure, if they've come in for their initial triage and you're just getting vitals and their hand starts twitching as the blood pressure cuff increases, then be thinking about hypocalcemia. And of course it results in QT prolongation. So, serum calcium is low, less than 8.5. And then ionized serum calcium is also low. So this is what you're thinking about with a hypoalbuminemia, is the effect that it has on ionized serum sodium. So if you have the ability to check both, you're not going to get both on just a standard metabolic panel. It's something you have to ask for separately. But that will help tell you whether or not they actually have true low total serum calcium, or if it's a byproduct of their protein levels being out of whack. And then look at their serum phosphate, because that is going to help lead you down the hypoparathyroidism road if they're not already in advanced CKD. If they have advanced CKD, hopefully that's something that's already a known condition for them, and you're not the one who's getting ready to tell them for the first time that they have advanced chronic kidney disease. And then again, check a serum magnesium, because it's often low, just like with potassium. So if they're symptomatic or severe, give them calcium, IV. Monitor the levels closely, so you're going to be doing this as an inpatient. If it's asymptomatic, so like you just have somebody who came in for their annual routine well person check, and you check labs and they've got some hypocalcemia, then just give them oral calcium and vitamin D. And also potentially check your magnesium, because if it's low, none of this is going to help you. Hypercalcemia, primary hyperparathyroidism, and what did we talk about earlier? Malignancy. So renal, as I mentioned, renal cell carcinoma will do it, lung cancer will do it. Be thinking about that. If you have a patient who comes in with hypercalcemia and you're trying to figure out what's going on with them, if they look like it might be due to malignancy, you're probably not wrong, and you should investigate that. Other rarer causes, sarcoidosis, tuberculosis can cause hypercalcemia, and for both of those, it's due to overproduction of active vitamin D. And then milk alkali syndrome. It is extremely difficult to cause significant hypercalcemia as a result of dietary intake, but it is possible. So if you have somebody who's taking in too much calcium, the majority of it's just going to not be absorbed and it's going to be excreted in the gut, right? It's just going to come out in their stool, which we'll get into this later when we start talking about kidney stones. One of the worst things you can do for somebody with chronic calcium kidney stones is to tell them to calcium restrict, because it's nearly impossible to take in enough calcium to actually cause calcium kidney stones, because whatever your body doesn't need, it gets rid of. And if you're not giving them enough, then you're increasing their oxalate absorption, which leads to kidney stone formation. So it's really challenging for somebody to take in enough calcium that it actually causes hypercalcemia, but it is technically possible. They're usually not going to be symptomatic unless their calcium levels get above 12 milliequivalents, but they can be. And you're going to see things like constipation, polyuria, nausea, vomiting. Again, very nondescript, nonspecific symptoms. Again, a person with hypercalcemia can be at increased risk for nephrolithiasis, but it's not going to be due to the fact that they were taking in too much calcium. That's exceptionally rare. And then if it's severe, again, you've got your central nervous system manifestations: drowsiness, weakness, lethargy, stupor, coma, and again, evaluate for malignancy. And then to evaluate that, look at their parathyroid hormone and look for parathyroid hormone related protein, because that's likely what's going to be being secreted by whatever malignancy is present and causing that to be elevated. And then get a chest radiograph. Again, you're looking for malignancy or the presence of granulopatous disease, because again, TB can be a culprit here for hypercalcemia. And then on an EKG, you're going to see a short QT interval. Like with everything else, identify the underlying cause as far as treating it, and then hydrate them to help get rid of the excess calcium. And then if it's hypercalcemia due to a malignancy, bisphosphonates, just like you would use to treat somebody with osteoporosis, can be used to help push the excess calcium into the skeleton. It's also potentially helpful in terms of skeletal mets and preventing pathologic fractures. And like with everything else in emergency cases, dialysis. Phosphorus. Kidneys are the most important regulator. If you have somebody with chronic kidney disease, that's going to be the most common cause of hypophosphatemia. And in severe cases, you're talking about a phosphate level of less than 1.0 milligrams per deciliter, as opposed to milliequivalents per liter. And again, same nondescript, very non-specific symptoms, and then the cardiac and neurologic signs. But you may also see leukocyte and platelet dysfunction with phosphatemia, because phosphate is necessary for normal platelet and white blood cell function. So if it's moderate, it's usually asymptomatic. It's not that big a deal. You're just going to give them oral phosphate to help get them back up. If it's severe, you're going to replace it by IV or potentially dialysis. If it's chronic, oral replacement is preferable rather than IV replacement, even if it is severe. And then again, you got to be careful with patients that have hypoparathyroidism or advanced chronic kidney disease. They always check a phosphate level on patients who are on dialysis, because their phosphate levels can get really wonky really fast, and so that they're always correcting phosphate on dialysis or giving. Patients who have chronic kidney disease, whether they're on dialysis or not, are often on phosphate binders to help flush any phosphate that they're bringing into their diet out in their stool. And then, yeah, be careful if they've got hypercalcemia as well. So in hyperphosphatemia, again, usually they have advanced chronic kidney disease. A lot of them are on phosphate binders of some sort to help prevent them from getting a buildup of phosphate. And then Clinical manifestations are going to be those of the underlying disorder, whatever it is, whether chronic kidney disease or what have you, and treatment, underlying cause, reduce or eliminate the exogenous sources of phosphate, and potentially put them on a phosphate binder or put them on dialysis if they need it. And then finally, magnesium. So hypomagnesemia is a level of less than 1.8 milligrams per deciliter, milliequivalent per liter. Just because their magnesium levels are normal in the serum, that doesn't mean that they don't have hypomagnesemia from a total body standpoint, because only 1% of your total body magnesium is in the extracellular fluid, which means you can't really measure it all that accurately. So be thinking about magnesium everywhere that we talked about, check their magnesium. Even if their magnesium is normal, you might still want to give them magnesium, because so little of it is actually in the serum and therefore measurable. Again, diarrhea, alcoholism, aminoglycoside antibiotics can cause hypomagnesemia in acute situations. So if you've got somebody who's like on IV gentamicin in the hospital, they may end up developing hypomagnesemia. Hopefully you really never have to see a patient on amphotericin B, because if they're on amphotericin, they've got big problems, right? We're talking multi-drug resistant fungus at that point. And then chronic PPI use is probably the most common cause. So if you have somebody who's on a PPI for GERD and has been for a while, then make sure you're checking their magnesium from time to time, because they may end up with hypomagnesemia. Same non-specific symptoms, same CNS effects. And then as far as laboratory findings are concerned, if you check a urine magnesium, which you're probably only going to get on a 24-hour collection, look for magnesium wasting. And again, electrocardiogram changes, prolonged QT interval. Torsades. I've seen torsades once or twice. It's pretty wild. You'll never forget it. You see that on the EKG and you just go, oh wow, that's not normal. Even I know that. So how do you treat it? Give them magnesium. If it's chronic, then just oral magnesium. Slowly replace their magnesium levels. If they're symptomatic or it's acute, then you want to give them IV or IM magnesium sulfate. And obviously, if they're in torsades, then you're really going to want to try to replace their magnesium levels quickly. So you can see here it's 1 to 2 grams of magnesium over 15 minutes. And just be cautious of patients with CKD as usual. Giving somebody IV magnesium is generally not fun for the patient. Has anyone ever received IV mag? Like for preeclampsia or anything like that? Anybody actually gotten IV mag before? I haven't, but my wife has, and she hated it. They put her on a magnesium drip, actually, because she developed preeclampsia with one of our children, and it was driving her up the wall. And she was begging them to turn the magnesium off. So just know that it's not necessarily a fun thing for the patient, but if it's necessary, it's necessary. Now, hypermagnesemia is probably because they're just taking magnesium, or they have chronic kidney disease. So if they've got chronic kidney disease, it's a slam dunk, but otherwise, it's probably because they're taking magnesium in large quantities, either consciously or unconsciously. And lots of over-the-counter antacids are calcium-based, but a lot of them are magnesium-based. And if the patient isn't reading the bottle, then they're not necessarily going to know that. So it's a good question to ask. If you see somebody with hypermagnesemia and they don't have chronic kidney disease, ask them if they've got heartburn, and ask them if they take lots of over-the-counter antacids for that, because that may be the underlying cause. Signs and symptoms, same non-specific stuff, including neurologic manifestations. They may end up with respiratory muscle paralysis and cardiac arrest at the far end, so be cognizant of that. And then, again, you're going to be looking at their serum magnesium levels, look at their other laboratory levels in terms of renal function, what's their BUN, creatinine, their other electrolytes, and then EKG. treat it by making them stop taking their Tums or Rolaids if that's what they're doing. If they're on, if they've got chronic kidney disease, you might have to give them IV calcium chloride, or you're just going to dialyze them if they're already on hemodialysis. For some patients that have chronic hypermagnesemia, they end up being on peritoneal dialysis, which we'll talk about more in another lecture. If you're not familiar with the difference between hemodialysis and peritoneal dialysis versus chronic renal replacement therapy. And that's it. Questions? I know this was a lot.